I'm the president of the Orleans Citizen Forum. For those who are coming here for the first time and to a forum, let me describe just what the Orleans Citizen Forum is and does. The forum is a nonpartisan, non-profit organization that brings forums on issues important to our citizens that affect their quality of life. Tonight, the forum is on what's new in Cape Cod healthcare. We have invited a group of very leading and very distinguished medical experts to answer your questions. One thing I would remind everybody to do is turn off your cell phones, please, so they don't go off during the meeting. Before I introduce the moderator, I want to clarify how we operate. I've been asked if the town funds our forums. The answer is no. We receive no town, county, state, or federal funds. Our only source of funding is our membership dues, which, by the way, is only $10. It's the cheapest club in town you can join. Our dues, though, are increasing to $15 on the first of the year, January 1st, 2013. So please take one of the envelopes on your chairs, or get on our website, or take one of the membership cards and join up, because we need you to help us run this forum. So now let me introduce our moderator, who is Dr. Sam Corlett, a surgeon who is now retired, but was also a professor of surgery at Harvard University. And he is also a resident of Orleans, so please welcome Dr. Corlett.
Thank you, Ed, and thank you all for coming out on this night a bit damp, but I hope it doesn't dampen your enthusiasm for a wonderful panel. The format for tonight will be, first I would like to introduce our guest speakers, and then ask each of them to make a presentation about what they do, and especially what's new and what's happening that would be of great interest to all of us in their fields. And after that, we'll have a question session, and I would ask that as you ask questions, please direct your question to a particular panel member who will then respond. And we'll speak more about that in a moment. So I would like to introduce our guests, not necessarily in order of appearance. First is Sharon Gale. Sharon, smile and wave. She is currently the director of outpatient rehab at Spalding Rehab and Physical Therapy. She has a Master of Science in Healthcare Administration and is an Orleans resident now for over 10 years. Martha Troutman. Martha is Community Relations Specialist for VNA of Cape Cod, and she has a key role as the principal liaison between the providers, the doctors, and the nursing facilities on the Cape. She was trained here on Cape Cod in nursing. She has a special interest in women's health issues. Dr. Munir Ahmed, MD, has practiced internal medicine at Cape Cod Hospital and was also a hospitalist there. He is now the director of hospice and nursing home care. He trained abroad and also at University of Connecticut. And since being on the Cape, he's gotten into many, many things here with great enthusiasm. Now, our own George Deering, Jeff, is captain at our fire department. He has extensive training in fire and occupational safety issues. And his current role is as emergency medical director and of emergency services. He not only provides the services personally, he organizes the service, he trains others to do that, and supervises overall quality. So he's a treasure in our community. And last but not least, Dr. Alan Ward, MD, who is Associate Medical Director of Broadreach Hospice and Palliative Care at Liberty Commons. He trained at UMass in internal medicine and has had a long-standing interest in palliative care. So, without further ado, we'll go to the panel, and we'd like to begin with Sharon. If you would, Sharon. I'm sorry, we're going to go in the order maybe that they're organized and start with Jeff. Is that all right? Good. Go Jeff.
Good evening. A couple things I'd like to point out. First of all, I'm honored to be here on behalf of the Orleans Fire Department to to talk about some of the services that we deliver as an organization to our community and our visitors and residents. We are proud to say the first line in healthcare, and it's exciting to sit up here with so many of my colleagues that are part of a system, but oftentimes we're the first line of what we do as far as when people need healthcare. We've, as an organization, done several things in the last couple of years to increase our capabilities. One of the biggest projects we've undertaken is providing data collection. We've gone from paper records, like many healthcare agencies, to computerized records. And what that has done for the end user, the people who use our services, is streamlined our services. So when we have many people who use our services regularly, we already have their records in our system. We can compare what happened the last time we visited them. And also, if those people are unable to speak due to illness or injury, we can look them up at the computer and say, we know what's going on, we know the medicines they're on, those kind of things. So it was a tremendous project. It was funded through our ambulance billing. It was a big project, but now it's up and running. I gotta say that my guys are no longer mad at me about it. It's streamlined and it's working well. The other thing that we've done, and then I want to talk a little bit about what happens when you call 911, is we've got new cardiac monitors. And although that sounds like a simple thing, it's a big thing. One of the centerpieces of the ambulance, other than the paramedics and EMTs that care for you, is the cardiac monitor. It's a device that can shock your heart if it's in a bad rhythm. It can help us determine if you're having a heart attack. It can, if your heart's going too slow, we can speed it up. It also can tell us how much oxygen is in your blood, tell us how much carbon dioxide you're exhaling, and one of the neatest things it can do is also tell us how much carbon monoxide is in your blood, and that is a new technology that we just got in the last couple of years. It's a tremendous technology. One of those devices costs about $35,000 a piece. We have 3 of them, and they were funded all through federal grants, so it was a really exciting project because they're computerized, and we had computerized monitors that were 10 years old. If you know anything about computers, that's old for a computer. So we were due. More importantly, I'd like to talk a little bit about what happens when you call 911 in Orleans and what to expect. If you pick up the phone and dial 911 here in Orleans, it's answered at the Sheriff's Dispatch Center, which is at the Otis Air Base. They will ask you what type of emergency you're having, the location of your emergency, and then it guides you through a series of questions to determine exactly what type of resources we need to send. While they're asking you those questions, someone's on the phone asking the caller questions, there's another person who's simultaneously putting that call out. So common misnomer is that the longer they keep you on the phone, the longer it takes for us to get there. That's not true. Those services will be putting on the road right away. Typically, they will provide instructions on how to care for someone. So if you're bleeding, how to take care of it. If someone's not breathing, how to help you with that. Those kind of things. And in hopefully 4 to 6 minutes, which is our typical response time, you're going to have 3 highly trained EMTs and paramedics at your door who will assist in any way we can. We'll provide oxygen, we interview the patient. In the ambulance, we can deliver 36 different medicines, give cardiac monitoring. We're trained in how to diagnose heart attacks, different things like that, strokes. And then we can call ahead to the hospital and pass that information on to these fine folks to get those services to you even quicker. The big thing I want to say tonight is if you think you need 911, you do. Don't hesitate to call us. We're there 24 hours a day, 7 days a week. It's not an inconvenience for us. That's what we're here for. So please call us.
John.
Good evening, guys. Thank you for coming to this forum. I work for the hospital, and I worked there for 7 years as an inpatient doctor. I'm working as an outpatient, so I see both sides, inpatient and outpatient. At this time, I'm going to give you some updates about the Cape Cod healthcare. As you know, the Cape Cod Health, basically the hospital itself, the ER, we need expansion. And it's right now in the initial phase of expansion. We are trying to get it about over 10,000 square footage area more because we serve about 90,000 patients in a year. It's the busiest ER in the New England. So we need to expand it. But again, it's going to take some time. Again, there are a lot of people, when I was working in the hospital as an inpatient in the ER, there are always issues, the privacy. When I'm talking to the patients, there's no privacy itself. So we kind of create something as basically the private rooms for the patient itself in the ER. So that's a big thing that's coming soon. Next thing, in fact, a lot of my patients asking me about hospice. What hospice is like? What they do? So they are inpatient doctors. They take care of you while you're in the hospital, especially in the critical care or regular floors. Also, when your primary care doctor doesn't go to the hospital, they are the one going to be taking care of you. So right now, amazingly, like only 5 or 6 doctors on the Cape, like in Cape Cod Hospital, only 5 doctors or 6 doctors, they go to the hospital, primary care doctors. So we are the one providing great care to the whole community, the hospitalists. So that's what we have right now as a hospice, and also we also basically doing a few things in Chatham. There are new health centers in Chatham. We're hiring new physicians for Fountain Medical and Nasset family practices. We also establishing relationship between the local nursing homes at this time. I'm one of the medical director for Pleasant Bay, and they have really good programs for wellness programs, and there will be flyers out there, so you guys can check those out. And there are some case managers here, so if you have any questions, you can ask them about those wellness programs that's available for you guys. Also, I'm going to talk about like outpatient setting, because now I'm doing that part. There's also help there. It's called Dovetail program. Also helping hands. Helping hands, what it does, and it's helping me a lot in regards to my patients, because when they're folks, they're on basically 20, 25 medications, and they have like 5 or 6 or 7 doctors. So there are 7 hands in one pot. So when they see their primary care doctor 6 months, and then after that they come to see the doctor, there are different medications. So what I do, I send the pharmacist to their house. They basically sit with them, they discuss their medications, what they are on, the side effects, why they are on these medications. And then that pharmacist coordinate the care with the doctor and update the medications. So that's a great resource that we should use it and talk to our primary care doctors. So that's available. Also, I've been using nurse practitioners and PAs in my practices. And there's a confusion about using the PAs and NPs. A lot of people, they don't want to see NPs and PAs, they want to see their doctor. But in order to get you in same days, if you have any issues, you're going to be seen. Because let's say your doctor has 2,000 patients. How are you going to see you in timely way? But, like for example, I'm working with PAs, so I'm overseeing all those patients. So making sure the good care is provided by them. And I assure you that they are good practitioners, and they are providing good cares, and the doctors are there to help. So use them, please. But again, thank you for inviting me to this forum. If you guys have any questions later on, I will be happy to answer them.
Okay, I think maybe you're beginning to see a pattern here. Jeff gets you to the hospital, and then Dr. Ahmed takes you over from there and takes care of you, and then we're moving on to Mrs. Gale for the next step.
Good evening, and thank you for attending tonight. Spalding Cape Cod is, if you're not aware, is a 60-bed inpatient rehab facility on the Cape in East Sandwich. In addition to inpatient rehab, we also provide outpatient therapy services in 5 different locations: Plymouth, Sandwich, Forestdale, which is our pediatric center, Yarmouth, and the center that you're probably most familiar with right here in Orleans. In the past year, we provided over 80,000 outpatient therapy visits alone. That doesn't include our outpatient physician visits as well. So we certainly have a large market that we're serving in many different communities on the Cape. Probably the most important thing to talk about in terms of where we're going and what we're doing is the expansion of our Orleans clinic and the relocation of that clinic. If any of you have been to our Orleans site, you know that while we provide extremely high quality care, we're providing it in a center that is certainly not optimal in terms of space. So we will be moving in a matter of just a few weeks, just up the street, to a space that is twice the size in terms of square footage, that will provide us with additional private treatment spaces, a much more spacious waiting area, more privacy in terms of checking in and out, much like the ER where there's not the privacy that you'd like to have. We'll be able to provide that in a much better way. We'll have a conference room that we'll make available to community groups if they want to come in and hold meetings at our center. And we'll just be able to provide our care in a much better, more comfortable setting for all of our patients. So for all of you who've been to our current location, thank you for your patience, and it's right around the corner. We'll be there very soon. I also wanted to talk about a couple of the newer programs that we offer. One being our adaptive sports program. The Spalding Adaptive Sports Center offers to individuals who've had a disability the ability to give back to a sport or recreational activity that they've done in the past, or perhaps try something new. So we have clinicians who are trained to work with individuals with disability to get them back perhaps on the golf course, or to get them back in a kayak, have them go skiing again, and we have the adaptive equipment to support that as well. That's been a program that, since we've become part of the Spalding Rehab Network, has really begun to grow, and we're able to offer many more activities and many more recreational things to the people on the Cape who, this is a community that's very active, and people want to do what they want to do, and when something holds them back, we're there to try to figure out a way, to help them figure out a way to get back to what it is they wanted to do, whatever that activity might be. So that's been a program that continues to grow for us. Another program that we recently began with our Chief Medical Officer, who is a neurologist, is the Centers for Geriatric Neurology, where David Bowl, who is a neurologist, sees the patients in conjunction with a physical therapist and really does a comprehensive assessment of patients with neurological diagnoses, including getting information from family members and care partners, assessing function, assessing cognition, looking at medications. These two professionals spend upwards of an hour with someone on an individual visit, and if you've been to the doctor recently, there aren't a lot of physicians who have the ability to spend an hour with a patient and to really do that kind of comprehensive assessment to get a sense for what's going on from all different directions and at all levels, and really kind of come up with a comprehensive plan for how to move forward and what's best for the individual as well as the people assisting the individual. So that's something that we offer in Plymouth, Sandwich, and Orleans. And really here in Orleans, it's something that was obviously served a community need, because it wasn't long after we offered it that the wait time unfortunately extended and extended in order to get an appointment. So clearly there was a population there who needed this kind of a service. And that's really what we try to do. We try to look at what are the needs of the communities that we're in and how can we serve those needs. Another program that came from the same kind of an idea is our post-concussion program, different population. One of our physiatrists a few years ago, when the whole notion of concussion really started to come to the forefront, particularly with adolescent athletes, really took charge of it. He forged a strong relationship with the Nauset school system, as well as other school systems on the Cape. He took the time to do a lot of education with coaches and trainers and parents and families, as well as athletes, to try to understand the impact of concussion and how to recognize concussion and the importance of assessing post-concussion and deciding when can a child or an athlete either go back appropriately to the classroom, when can they attend to what they need to attend to in school, when can they do the appropriate amount of homework, when can they get back on the field, when can they practice, when can they play in a game. And he's worked very closely with primary care physicians as well as school systems to try to manage these adolescents post-injury as best possible so that they're safe when they go back out there and that they have the guidance and the parameters that they need to know in terms of what they should do and when they should do it. In conclusion, I guess I'd just like to say that what we try to do is to identify the needs in the communities where we're present, and certainly this is a community where we've been present for 15 years now. We opened here in 1997, and so we're always looking for feedback from the people who we serve, and that's all of you. And if there are ideas or areas where you feel services aren't being provided in the world of rehab, then we're happy to hear that and take that feedback and hopefully provide some services and programming that will meet that need. Thank you.
Good. Now we'll go on to learn more about our nursing facilities with Mrs. Traub.
Hello, everybody. Thank you for the invitation to tell you a little bit about the VNA. The VNA, or Visiting Nurse Association of Cape Cod, we've been around with our 96th year right now. We are with our humble beginnings back in Falmouth in 1916 with one nurse and one bicycle. So we've come a long way. We now cover the entire, our organization. When you hear Visiting Nurse Association, I know that it's a national, you think a national company. It really, you have to sort of, we are a local company. We fall under Cape Cod Healthcare. But Visiting Nurse Association is sort of, it's like being a member of AARP. They advocate for us, they keep their finger on the pulse of the newest rules and regulations regarding health care in the home care in the United States. So, but VNA of Cape Cod is local. We are a not-for-profit organization, and we provide a whole series of menu of services, but primarily what we call certified services, and those are home care services provided under insurance plans. So Medicare is our biggest payer for services, and every one of our patients has then been referred. So we may get a referral from the hospital or physician, or from RHCI outpatient, or from one of the nursing homes, or simply from a neighbor, or even the fire department. The EMTs might make a suggestion that you would benefit from home care, and then it would be paid for through Medicare, your insurance plan. Certified services include nursing, physical therapy, occupational therapy, social work, speech therapy. So anything to improve your health and well-being and safety in your home. The only requirement for certified home care is that you are, under the rules of Medicare, that you are essentially homebound and you need a skill. So essentially homebound means that it takes a taxing effort to leave your house with usually the assistance of a person or a device. And it doesn't mean you can't go to church or get a haircut or go to your doctor's office. But these are, like I said, we follow the rules of Medicare, and so we're able to go into your home at any time to provide these services if you meet these requirements. On any given day, the visiting nurse is in between probably 1,100, 1,200 homes each and every day here on Cape Cod and Plymouth, all of Wareham. We cover Mattapoisett, Middleborough, so we're a large agency. We employ probably 275 nurses and another 30 therapists, physical therapists, and occupational therapists. So in home health aid. So we are, we provide services that you don't really know anything about until you need them. And anybody, like I said, can make a referral. If you were concerned about a family member, a neighbor, you can always call the VNA, and we would put the wheels in motion to see if both they met the eligibility and had a physician. We have to have a physician who will agree to the plan of care for the patient. We also can provide, injection therapy. We can do infusion therapy, IVs in the home. Back 30 years ago, 40 years ago, or even probably 20 when I think about it, if you had, if you needed IVs because of an infection, you stayed in the hospital for 2 or 3 weeks during that therapy. And now you're there 2 or 3 days, and then you'll advance to one of the skilled nursing facilities, or you'll go to home, and we'll help you and provide those services in the home. We're also very involved with maternal child health. We get referrals for nearly every baby born at Cape Cod Hospital or Falmouth Hospital for new baby visits to assist mothers in their new, just sort of instructional and to assess how things are going in the home. We are also the provider of town nursing. We are the town nurse for 13 of the 15 towns here on Cape Cod and 2 off Cape. And those, in that, you know, it always is a little different every town. So they purchase from us services, and we provide the service, the care. And that may be health education, it may be health screenings, it may be home visits in the home that don't fall under certified care or insurance care that the town then pays for. We also are the provider of immunizations, flu shots, shingles vaccines. Last year we gave 33,000 injections on Cape Cod for the flu, pneumonia, shingles, and we do adult children immunization as well, so pre-kindergarten a lot of the time. We're the provider of those services. We have different programs we offer in the community. We're very community-minded. We have a free ostomy clinic for, where we can provide support and just sort of observation of an ostomy, new or old. We have wound, WOCN, wound ostomy continence nurses who are specialized in ostomy care. They can even fit for hernia belts or anything. Again, if you don't need it, it doesn't really mean anything to you. But you know, we've seen people in these free clinics where they've had their ostomy maybe 20 years and they've never really advanced their appliance. We keep our finger on the pulse of anything new and innovative out there that we can just, again, assist in better living for somebody.
Terrific. Yeah.
I talk too much?
Another chance.
But anyway, we also have an adult day health center right in Harwich, which is a medical model. So if we're able to meet the needs of people who need a little help during the day, and their family member, you know, for safety purposes, needs to put their adult family member into a daycare situation, we have one right in Harwich. And I'll answer any questions later.
Big job. Now, to the last but far from least, Dr. Ward to tell us about his.
I can see why you put me last.
Easing our way to the end.
This forum is on what's new in healthcare, on medical care on Cape Cod. Well, hospice is not new. In fact, my friend Mary McCarthy started hospice in Falmouth in 1981, which continues today as Hope Hospice, which is a new name for hospice at Cape Cod. But what is new to me is hearing over and over again how really uninformed the general public is about hospice and how many misunderstandings there are and misconceptions about hospice and what it offers. One of the things I've heard for years over and over from families is, why didn't someone tell us about this earlier in my mother's illness? And another one was, well, my mom just died in the hospital and she'd always wanted to spend her last days at home. Why didn't I hear about hospice? The Medicare hospice benefit was passed by Congress in 1982, and it had 2 requirements. One was that a patient had to have a life expectancy of 6 months or less, and then subsequently was added, given the expected course of the illness. And the second requirement was that the patient must agree that he does not want more aggressive, curative, often futile therapy given. Hospice covers a number of parts of the terminal illness. It pays for all of the medications related to the patient's illness. It pays for durable medical equipment such as hospital beds and oxygen. It pays for nurses' visits, home health aides, also for spiritual counselors, social service help, and also physician visits. And hospice can be delivered anywhere the patient is. We prefer it in the home if we can do it, but if it's necessary, it's done in the hospital or in nursing homes. Well, what are some of the misconceptions? One is that you can only live 6 months in hospice, but the fact is that given the course of the patient's illness, there are a lot of diseases that are not predictable. So that means that every 6 months, the medical director recertifies or determines if the patient is still appropriate and recertifies the patient. I had one woman who was a hospice patient for 4 years before she died of her disease, and she was still considered hospice eligible. Another is you have to have cancer to be a hospice patient. Well, initially, in 1982, that was the case. Most patients did have cancer, but now only about 45% have cancer. The rest have chronic lung disease, end-stage heart disease. The largest number have neurologic disorders, and in particular, Alzheimer's. And another is you have to be in severe pain to be a hospice patient. Well, that's not true. Hospice personnel staff are very, very good at pain and symptom control, but patients can come into hospice as soon as they are deemed appropriate by their physicians without necessarily any symptoms. And the last might be, there's only one hospice on Cape Cod, and as you know, VNA has a hospice, and there are about 5 hospice organizations here on Cape Cod. Well, what about palliative care? Palliative care is a newer concept, although certainly not new. And it is a program that is not offered by Cape Cod Healthcare, pretty interestingly. But all of the hospice programs do provide palliative care, and VNA has, we have it at Broadreach Healthcare. So it does exist here on the Cape. Well, what is palliative care? I describe palliative care as a bridge between wellness and hospice. And so if a patient has a life-threatening illness, he can receive palliative care, which includes pain and symptom control, education regarding his disease process, assistance in deciding what his next step might be. For example, I just spent some time with a patient who wanted to stop his kidney dialysis. And his family was bonkers over this, but he had many good reasons for wanting to stop, and we had a long discussion about that.
Well, perhaps we can pause there.
Can I include two more sentences? Okay. The difference is that palliative care has no time limit. It can be done throughout the patient's entire course of illness, and secondly, curative therapy can be given throughout this time also. And we have patients who go through palliative care and are ultimately discharged. So palliative care, although not new, is something that I think is going to be a very important part of the healthcare system.
Well, I am impressed, and I thank you all for your very wise contributions and for your amazing ability to confine it to 5 minutes. Complimenti. Now we're going to open to questions, and the format will be, again, please direct your questions to an individual panel member. There will be a roving microphone, and that panel member will then answer the question, we hope, and then any other member of the panel may wish to chime in, or 2 or 3 add more comments to the first commentator. And of course, the panel members should feel free to ask questions of the other panel members. So here we go. Raise your hand. Our microphones will be around. What questions? Well,
Dr. Ward, if I could, question, you mentioned the cost involved with this care. It sounds something like you said that you provide these services. Who's actually funding this?
Medicare funds it. Medicare funds everything that I mentioned, the meds, the visits, the hospital bed, and so forth. It does not, however, fund 24-hour-a-day care. That is on the patient's own dime. But the hospice does offer guidance as to how to achieve that.
Other questions?
Does long-term care insurance, do you work with that?
I can't answer that well.
Or anybody?
I think long-term care, well, what I've heard is that every policy is so different that you would have to sort of study your own policy, that there's no broad answer for that.
Could I just say that it may cover, say, the patients on hospice and receiving benefits under Medicare. It may be that it would cover some of the extra care, like 24-hour people being in the home. I don't know how much of that. Again, that's policy independent too.
There is a microphone over there. Thank you all for that presentation. For any of you, what are the pros and/or cons of the Affordable Health Care Act on the services you are currently providing at a reasonable cost to us? Dead silence like the audience. Thank you.
Dr. Ward.
I think that hospice is going to be an important part of the Affordable Care program, because it's going to try to bundle all of the services for a patient into one program. And I hear the term medical home, and so I think that even though it's cost saving, they never mention that, because that's a no-no when you're talking about people's health. But it is less expensive to have hospice care. But I think that hospice and palliative care will be benefit from such a program.
I'll just add that I think that we are all in our different sort of silos of healthcare right now going to have to work far more collaboratively in the future with the direction that healthcare is going.
Yes, over here.
Mrs. Gail, can you give me the name of the physician at Nauset High School that works with concussions?
He's not at Nauset High School. He's our physician, Andrew Judelson, Dr. Judelson.
Okay.
He's a physiatrist by background, but he forged the relationships and the pathways and developed a very strong relationship with the athletic trainer first at Nauset, and has gone on to do so with other school systems as well in the Cape.
And where does he work from?
A Sandwich in Orleans. He's in Orleans on every Tuesday.
Okay, thank you.
And he's in Sandwich otherwise.
Other questions? Yes.
Yeah, just a quick question to Jeff. How far back does your computer database go, or is it from this point onward?
We started it October 1st of 2009. So from that day forward, at that particular point in time, using the town census data, we were able to put in names and addresses of 6,000 town residents. It does not provide medical information for any of them, but we have proper spellings and addresses. So on the way to a call, we can look up an address and see the people who live there, and oftentimes, if we've been there before, we can refer into the calls that we were there previously. So it's not 30 years worth of data, unfortunately. It's several years, but it's built up to a much bigger system than it started already.
Are you going to try to go backward at all, or you just hit a brick wall?
If you saw the stacks of papers that we have, no. But going forward, where we're headed with it is now integrating the monitoring side of it, the cardiac monitor side of it. We can put people's EKGs in there. So if we bring you in March with chest pain, we can, and then we bring you in November, we can compare EKGs to determine if you've had a cardiac event. That's where we're headed with that. So the technology is, we're still building up with it, and then the next piece we're doing with that as well is integrating it with our dispatch. So when you call 911, data will populate into the program as far as the address of the call simultaneously, so that stuff will already be there. So there's a lot of different things we can do with it. We're just building it up still.
Yes, over here in the back.
Yes, good evening, Chief. I live in Eastham, and we've used the EMS services a couple of times. They're pretty terrific. We also have a lockbox. It contains the key and the deadlock key to my house on the banister of my front door. And they can get in if nobody's can open the door of the house. And then it's a good idea, you know, they can come right in. Is that a universal key? Do you have that in your community? If you're filling in for the Eastham EMTs, do you have a key to that lockbox?
That's a great question. No, we don't. Every community has an individual key. Those keys are kept highly secured, so not just anybody can have a lockbox key. Only the fire department has them. So the short answer is no. That if we're called into Eastham to open your lockbox, we'd have to have someone from Eastham come meet us with that key. They're not universal.
Okay. Is it flagged on the computer, the GPS maps that you use, if there is a lockbox key to the house?
In our database, yes. If you in Orleans, if you have a lockbox that was come through the fire department, yes, we do track that through our dispatch software. That we know that not only do you have a lockbox in your house, but it's on the banister next to the front door.
So if you're substituting for Eastham, if their two trucks are out, you would have to ask them about that information.
That's correct. Yes. But we have great radio communications that integrate throughout Cape Cod and off Cape as well, that we can communicate with those dispatch centers if it's a different dispatch center.
Well, we really appreciate the work you all do. Thank you.
Thank you.
Yes, over there in the back.
This is for Dr. Ahmed. I've been reading that there's a plan to develop a very exciting new facility at the hospital, the emergency room. Could you tell us a little bit about that and when we can expect to see that?
Still, as I said, is in the planning phase right now. Actual plan, as I mentioned before, they can expand about over 10,000 square footage area. It will be in early 2011. They did a small expansion and they created a secure area for the psychiatric patients at the Cape Cod ER to separate the two, basically just for routine ER visits and the psych patients. Now the plan is to again expand, but again, as I said, I don't have the actual information yet. It's still in the planning phase right now. So, but it's coming, but still I cannot give you the whole information that when it's coming, but it's still in the planning phase of expansion.
But I think an important thing is that each patient will have his own room.
Yes.
It won't be stacked up in the halls like they are currently.
Personally, I basically feel like, as a physician, when I'm seeing a patient, feel like I'm in a fish market. Because you cannot talk to the patient. There's no privacy. And that's basically one of our concerns as a physicians, and especially for the patients, because you cannot even examine the patient in those corridors. And so it's coming. So we just need some patience, and things can happen.
I'd like to just add on to that. I've been following this pretty closely because this directly affects stuff that we deal with on a multiple times a day basis. We're excited about this as a group because one of the things that we run into is there's no privacy for the patients, and it's hard to move. When we bring patients in, particularly critically ill patients, it's hard to move. We're looking forward to this. And I will tell you that in my experience, I warn patients as we're on the way to the hospital, this is what to expect when we get to the hospital. You know, you're going to be greeted by a nurse, you're going to be greeted by this person, that kind of thing. But when we turn the corner and come through the doors, it's going to look like because if you've been there, it's a very, very, very busy place. They have tremendously talented people who work there, but they're working in a very small physical plant. And it's very exciting that I think will increase the quality of care in there and the patient experience, because it just is so tight in there right now that they can't move. They can't move. It's really exciting.
Also, I'm going to add one more thing. Is basically they also going to divert the critically ill patients and people who have heart issues or having an MI. They're going to divert. There will be a separate area for them. So that's exciting too, because you guys can bring those critically ill patients right there. So.
Do we have other questions? Yes, in the back. Our camera.
This isn't a question, it's actually a statement of information. The project at the hospital falls under review of the Cape Cod Commission, and the plans are available at the Cape Cod Commission website, www.capecodcommission.org.
Good. Thank you. Other questions? Yes, in the middle. Back.
Where's the Orleans Spalding facility? Where's it now and where's the new one?
It's currently at 21 Old Colony Way, and it's moving to 65 Old Colony Way. So it's same street, brand new building.
Want to go first here?
I could ask, fortunately I haven't had this experience, but you read in the paper about tragic accidents, etc., where decisions are made to fly the patient to Boston. Are you making that on the scene kind of decision?
Yes. We use a standardized treatment protocols for a lot of different things, but one of them is trauma care. And we have a standardized process in which we follow based on the type of injuries that the patient has, those kind of things, and also the availability of trauma care. So one of the challenges on Cape Cod is we don't have a trauma center, which is a certification, a national certification that a hospital has. In so much that there's none in southeastern Massachusetts, the closest trauma center is in Weymouth. So that's why we fly patients into Boston, because we know through long-term studies that the sooner a patient who has significant trauma is in an operating room, the better they do. We actually have a term for it, it's called the golden hour. So the sooner we can get them there, that's what we do. So we look at things like, are they available, how soon can they get here, that kind of thing. So you'll see them either fly to the scene or into a landing zone in a community or to the airport and meet an ambulance and to get the patients to wherever, typically to Boston. The service that we use is based out of Boston, but they'll fly into Rhode Island or other places if necessary.
Let me have to fly here first, pick them up and go back.
Yeah, that's what they'll fly here. The closest helicopter is based out of Plymouth, so they can be in Orleans if they're at the Plymouth base in about 9 minutes. It's pretty awesome. And then they can be in Boston in another 16 or 20 minutes, depending on where they're going.
Okay. I'd like to address this to Ms. Troutman and Dr. Ward, that even though the assisted suicide item on the ballot was defeated, I wondered whether you thought about how you might be or might not be involved in this if it were passed.
Yikes. I don't know. That's a good question. And I think that we have, I'll be curious to see if it reappears on the ballot and rewritten maybe to more specifics. Because people did talk about it. We did, even a lot of our patients or clients discussed it. Not a lot, but a few. And their feeling was, that they should be allowed this. That assisted suicide would be, if I've been in home care for 20 years, and the one phrase that I heard over and over again was, these were supposed to be my golden years. And they were people who were just they were so tired, and so sick. So I don't know, I don't know, I'll be curious to see where it goes, but I don't.
I've been involved in several forums on this topic, and I was going to add before I would stop that this topic is very important, and that it's been shown that the states that have passed this death with dignity law, Oregon and Washington, have a much higher per capita use of hospice and palliative care. and that although there are not a huge number of people who get these prescriptions, only a certain percentage of them make use of them. And a number of them are in hospice care and never make use of them. But it does promote, I think, better end-of-life care, even without using the pills. So, one of the scare tactics of the articles against it were, number one, that it was a strong narcotic. Well, it isn't, it's a barbiturate. And second, it takes 100. Well, it certainly doesn't take that many. There were just a lot of scare tactics around it, but the fact was that the wording is very similar to the Washington and Oregon ballots that were passed, and the one in Oregon has lasted 15 years without a dramatic rise in the number of cases or much or any that I've heard of misuse. So I think that it's a reasonable thing. If I were asked to write a prescription, I doubt I would do that, but I would favor how it would improve the care at that time of life.
Okay. Yes. We have them right here, and then we can go over there.
I'm thinking about the elderly who do not have good family support and in need of medical care. How do you handle that case?
This for Dr. Ward?
Well,
Well, the biggest problem on the Cape is that we're all wash ashores, and our families are all spread all over the country. And we're from Worcester, right? And in Worcester, all our families were around us. And some people in Worcester never leave the same neighborhood where they were born. And so it's very different here. And this is why these efforts at community organizing support for everyone keep popping up, because I don't think any one organization can accomplish it by itself.
I think that, I'm sorry.
Go ahead, Mr.
Well, I was going to say, that seems to be, it's a challenge we see each and every day in the community with, because people fail to plan a lot of the time, because families are so far away. And mom and dad seemed fine, or mom seemed fine when we saw her last summer. And then we just sort of react as opposed to being proactive, to put plans in place or just sort of assessments. And even this, I just saw something on the Today Show or something about over the holiday when you're visiting your families, when you're going home and seeing your parent or your grandparent you haven't seen in a while, to make an assessment. Are they having trouble on the stairs? Do they seem like they've declined a bit since the last time you saw them? Is their vision, is their house dirty because they're not seeing when they're cleaning up? What is the decline? Are they short of breath when they take the stairs? So that was sort of like an all call to check on your family that does live far away. So I think that we're always challenged every day with trying to find resources for people who are alone and without services.
This is something we run into every day that I deal with. Is shift A will be to someone's house one time, but another shift will be there another time, and over the course of a week or two, Mr. Jones has fallen down 6 times, but we haven't picked it up because my different crews are there. That's some of the stuff that I do, is look at those patterns and try and figure out why is this person calling so much and what types of help can we get them. We use a resource through our Council on Aging called REACH, which is a community action thing where we identify people who are at risk for falls or need additional help with medical, home health aides, things like that, and we pass it through them. That's kind of our mechanism. We also work with people's families. We'll reach out to VNA, whatever we can do there, primary physicians, to try and get people into the system. Is that we are kind of out there helping people up, but we're not always the best resource to give them the assistance that they need for the longer term, and trying to get them into these different resources that are here. That's something that we are involved in every day.
think it's a coordinated care overall, and it's a part, like basically, now I'm doing the primary care. Primary care should be a center, like, because a lot of people, their family or their sons or daughters live like in California or somewhere else. So what I do as a physician, basically I arrange a few things for them, as I said before, the helping hands. I send the VNA to check them out. Also the elder services available, making sure they're safe enough in that environment. If they're not safe enough, then we try to contact the family members. What's available to them, like financially? That can we get them to the assisted living? I got like, I think 3 or 4 folks into the assisted living because they are not safe. So these are things like it's a coordinated community, to get them involved and get some help for you guys.
Likewise, from an outpatient perspective, we'll often have people coming into our clinics, and the clinicians, because they work so closely with them, will identify that there are additional needs, or perhaps the person isn't even safe in coming to outpatient. And we'll either connect with VNA. We also have an outpatient social worker, case manager, who is a great resource in terms of community support and resources, and we'll make that connection as well.
Okay. Yes.
This is a question for Captain Deering. Tonight is the first time I heard about a lockbox. Is that something that you recommend for us to do? To have a key available to you in case of emergency?
Yeah, in Orleans, if you have an alarm system, whether it's a fire alarm system or a medical alarm, so one of the lifeline type devices, it's actually required by bylaw that you have the lockbox. And what it is a secure box. Some of you might have seen like a real estate one where they have a combination on it. But the ones that we utilize in the fire department, and this is true for all the fire departments on Cape Cod, is a specific key that only the fire department has to get in there if there's a medical emergency. So we don't have to break down the door kind of situation. They're available through our station. If you come into the station or give us a call, there is a fee associated with purchasing the box through the company that makes them. We don't make any money off of them, but and then we will come in and install them as well. And it is a time saver when there's an emergency. Just today, my guys had to force a door on a house to get in for someone who had fallen and had been on the floor at least overnight. And if that person had a lockbox, we probably would have gotten in there just a little bit quicker. But it's that kind of thing that you don't think of until you need it. I would strongly recommend you check it out. It's one of those things that does save time for us. And just a quick, on the table out front, we put a Files of Life. If you're not familiar with that, it's a medical information card that goes on your refrigerator. It kind of travels with the lockbox in my world. When we get there, if you're not able to speak, we are able to get your medical information, has your medications on it, that kind of thing. So it's tremendously important that you fill those out. The lockboxes are very helpful.
This is a key thing, not only for the health issues, but particularly here on the Cape where we're often away, where people aren't here most of the year, for fire as well. And it's just a little thing about yay big, which is your house key. And they have the key that opens that box, and they get into your house for any reason that you're not there. Or if you're sick, you can't respond yourself. Thank you. Question? Yes.
This is for Captain Deering. We have heard that there are quite a few people who have little lockets around their head, their necks, and they're supposed to call the police department every day to make sure that everybody knows that they're all right. And if they don't call, the police will call them back and see if they're okay. Are you connected with that sort of thing?
We are. The police department manages the program. It's called the Reassurance Program. So every morning you would call in, I believe by 10 a.m. If you don't call in, it's just a simple call in, hi, good morning, I'm okay.
Yeah.
If you don't call by 10 a.m., then they send someone out to check to make sure you're okay.
Yeah.
Oftentimes people just forget to call or they go to church, things like that. But on many, many occasions, there's been something that has happened to someone where it's been recognized.
So you will be alerted to that?
Absolutely, yeah.
Okay.
Oftentimes it goes back to the lockbox question.
Yeah.
We usually have the keys to the house, so we'll get called to meet the police officer there to open the lockbox to go and check on the person.
Okay, thank you.
Go back there first, and then over.
think the speaker previous has a misconception. I believe that the necklace she talked about, the neck or the band on, watch band on the arm, is for the people that have the ability to press a button and help will come. And that has nothing to do with your reassurance program.
You're correct. They're separate. Is that some people have the lifeline type devices for medical emergencies, but the reassurance program is a telephone program where they pick up the telephone and call every morning.
Thank you.
A question for Martha Troutman. Just about the VNA services that you say that Medicare reimburses, is that a certain number of hours per day? Well, each patient, and they come up with a plan of care. But I wanted to also say, because as Dr. Ward said, that we do not provide 24-hour care. We do have a private division which will do it fee for service. But otherwise, no. It would be a unique plan of care developed for every patient, and it would meet your skilled needs, whether that's, a nurse twice a week, every day, twice a day, whatever the need is. And they would only come and perform their skill, and then they would leave. And then physical therapy comes in, occupational therapy, but it would be a unique plan of care for each person.
Is it subject to like 90 days or something like that?
We recertify, so when we admit a patient to services, they're certified under 60 days, but you can be recertified every 60 days.
And just one other question with regard to, is VNA, is it Massachusetts, is it the same as VNA in New York, for example?
Well, we all follow the same rules, but we're all different companies.
Okay.
We're separate entities, yeah.
Okay, next question. Yes.
Thank you all for being here. I feel very privileged that Captain Deering taught my basic life support class. I've been treated at Cape Cod Hospital on multiple occasions. I've had rehab at Spalding, inpatient. I work every day with the VNA who did my physical therapy after I came out of the hospital, and I'm avoiding Dr. Ward. If we could talk for just a moment about the difference between a do not resuscitate order and a comfort care form for people to have in their homes. And I also wanted to ask Dr. Ward if your hospice patients sign DNR orders.
Not necessary. It's not required. It used to be when the Medicare hospice benefit came out that I thought that was a requirement, but that has gone by the boards. I think a lot of effort is made to discuss the situation with people so that they can make their own decision, but it's not required.
I'd like to tackle that comfort care do not resuscitate order question because it's something that's important for us. A comfort care do not resuscitate order is one form that is recognized by the Department of Public Health that came out in 1999 or 2000 to kind of streamline the procedure in which people, if they did not want out of hospital resuscitative care, so if their heart stops beating, what would the emergency medical providers do? Up to that point, there was a lot of challenges as far as what a do not resuscitate order looked like. And to the point where it was written on a prescription pad, what was valid, what wasn't. There's one form that the ambulance crew can honor, and that's the comfort care do not resuscitate order. So even if that's something that you wish to have, you have to have that form for us as the ambulance crew to honor that. And we have a 6-page procedure in which to validate that, to make sure that we follow people's wishes for that, which we completely respect, but we have to do it through a process. Our guidelines, it has to have the name and the date and signatures and things like that. But at any time, if there's a question about the validity of the form, our orders are to start resuscitative care and transport the person to the hospital. So it can get a little sticky sometimes, but that's why those forms are out there.
This is important. I think we all need to think about if we had to be resuscitated and what would we be like when we came out of it. and just what circumstances would you not want to pertain if you came out, and what would you want to do, and it means defining fairly accurately just what kind of state of health you want to be and from which you want to be resuscitated or not, and maybe just expand a bit on who should have these forms. Everybody should, there is a form on which is documented that's a, I think, state-issued form, or can be found?
It is a state-issued form, and usually it's through people's physicians.
And who should have that form?
Anybody really can have one.
Where should it be kept so it's available to you when you show up?
We recommend if people have them to put them in your file of life. Put it there. And furthermore, we have the ability through our computer system, which I mentioned earlier, to actually scan them in and put it in as part of the patient's file. So if you have a family member that has one of these forms, you can come to the station and visit me, and I'll give you a cup of coffee, and I'll scan your form and put it in there so we can follow that. And then we put an alert, basically, when we pull that patient's information up that they have a do not resuscitate order in our system. There's a lot of other pieces to this, but I know the world in which I work.
I would recommend basically for when you see your doctor, there are Medicare now approved wellness program. Like basically, when you see the patient for your wellness visit, discuss these issues, healthcare proxy, your living will, and the primary care doctor are going to provide you that comfort care which you're talking about, and have it signed right there, and you can take it and you can basically put in that envelope that you have with your medications and the comfort care should be together. Because it's a big problem for us physicians and for them when the patient comes to the ER and they don't want to be resuscitated, and now they are on the ventilator. So I personally think that as a physician, I feel uncomfortable doing those things. So if we have those plan of action in place way before, I think when we are at the age of 65 or start talking to our physicians about the healthcare proxies who are going to be making decisions on my behalf. There should be somebody like your next of kin or your children or your spouse. So that's a very important thing that we need to discuss as a community, as with your spouse, and talk to your primary care doctor. I think like nowadays, as you all know, that when you go and see your doctor, they don't have any time. Like you go in there and you just come out like in 5 minutes. So personally, I think like basically as a doctor, we need to spend some time to talk to your doctor. There should be a designated time. This is wellness visit. This is the right time for you guys to discuss these issues. You're going to be discuss all those issues, your immunizations, your other things, medications, updated medications. These are the small things make our life very easy. Thank you.
A little bit easy.
I just want to mention that VNA has a wonderful document entitled 5 Wishes.
Yes.
And I think that's a document that, that really forces you to think about the choices that you want to make. And surprisingly, what you might find is how you feel when you're healthy and how you feel when you're not. Maybe 2 different ways. And you need to continue to revisit that document and make sure that you as the healthcare proxy really know what your significant other wants, so that when the time comes, you can honor that and respect that decision.
Other questions?
I just had a question for Captain Deering also, which was basically, I'm involved often in discussing and issuing, signing comfort care forms for people. But my concern often with those, I mean, I end up giving people copies of their form and is to where they actually wind up and how useful they are in practice. They used to have, when I first came to the state, we used to have little wristbands that were issued with these things too. Somebody was actually supposed to wear these little paper bands when they signed the comfort care thing, that they would always be, they'd sign the comfort care form. Anyway, I hadn't realized that you guys were able to actually scan forms in, so I'm just questioning whether, I mean, it sounds like it would be a good plan to be sending you those forms directly, perhaps by fax, and having you scan those in for people who are interested in doing that, rather than having them post them on the refrigerator or do things that are unlikely to be necessarily long-term available to somebody coming in and trying to make that decision.
I'm all for that, Dr. Reed. It's nice to see a familiar face. Within the confines of HIPAA, I have no problem, if the patient has no problems faxing it over, or I'll come down and pick up the copies. We always encourage people to make multiple copies of the form so they have them with them. In the previous versions of the Comfort Care DNR, you only could honor the original, and that was a headache. So now they encourage people, copies are valid, and we tell people, give us a copy, but also put it in the file of life, because for some reason the computer doesn't work, or another town comes, or it's just good to have that piece of paper in hand. So we still encourage people to have the paper. But I'm all for sharing that and putting it in the system.
I've been involved in healthcare for 40 years, and I set up hospitals all over the world. I used to teach graduate students in healthcare management, and I'd like to commend the panel for one of the best, most effective panels I've ever seen, and thank the Orleans Citizens Forum for this. We're very lucky to be on Cape Cod.
Yes. Joe.
As a past president, Ed, that was very well spoken. I'd like to drill down with two questions to the doctor from Cape Cod Healthcare, and I'm sorry I can't remember your name, but I can't see it either. Two questions. One on the hospital. Is the hospital a for-profit or not-for-profit? And will the hospital be better off under Obamacare? The second set of questions is, as a physician, will you be better off under Obamacare? Will you be able to spend more than 5 minutes with your patients? Please. Thank you.
It's a non-profit organization. It's a tough question, and unfortunately I don't have any answer, because Obama doesn't know that answer yet. What can happen with the Medicare, and what can happen with all care we provide? And I'm concerned as a healthcare provider. I don't have the answer.
I'm disappointed.
Me too.
Here again, and then, of course.
Okay, just another question for Captain Deering. Just in terms of staffing, how does that work? You obviously have a lot of contingency or redundancy built in, or what happens if 2 emergencies at once, etc., or a town emergency?
Oh boy. Typically, during the day, 8 a.m. to 6 p.m., we have 5 people on duty. We will drop down through sickness, training, other time off to 3. When those 3 go out on a call, we bring back 2 more people to cover them. If those people go out, we bring back more people. Those people come in from off duty. If we use all those resources available, or we use all the ambulances that we have, then we'll use our mutual aid plan. So we would call the closest town, and that's already pre-configured through maps and computers, so we know exactly where you are, we know which ambulance is going to come. That's already figured out. But it's a real challenge for us to get those ambulances on the road in a short amount of time sometimes. In the summer particularly, from April to the end of September, 70% of the time I have 2 ambulances on the road. So that's I'm very proud to say that we can get an ambulance to you 8 minutes or less, about 87% of the time. The national standard is 90% of the time, but there's just some parts of Orleans we just can't make it to. It just takes too long. But we're working on that. It's very hard to predict when we're going to have emergencies. If we knew exactly at 2 o'clock on Thursday we're going to have a whole bunch of emergencies, we'd have plenty of people working. But we can't quite, to figure that out. But our mantra, our organizational mantra is, if you call for an ambulance, you're going to get an ambulance. It may not be an Orleans ambulance, but you're going to get help, and it's going to be highly qualified. Everybody on Cape Cod is trained the same way. So, it's pretty seamless that way. But we're struggling to get that manpower part of it solved, so we always got that ambulance there for you.
Okay, over here.
Is there any jewelry that's recognized by the medical community that you can wear?
Medical alert bracelets is the main
Yeah, like
one.
do you not resuscitate and things like that?
We cannot honor, even if you have a medical alert bracelet, if it said DNR on it, we would not be allowed to honor that if you didn't have a Comfort Care DNR form.
Okay, other questions, yes?
Can you go over the bridge with the ambulance?
Yes. Some of our treatment plans would call for that. One of them is the trauma triage plan, where there is contingencies in place to transport people either to Rhode Island Hospital or to South Shore Hospital in Weymouth. Where we are in Orleans falls typically outside of that plan by time, but it is pretty typical of other services closer to the bridge to go to both of those places, and even into Boston directly. But we don't routinely go over the bridge. It's not the best use of resources. If we send an ambulance to Weymouth, it's gone for several hours, and that leaves the community slightly less protected.
What other questions? Yes. No? Let's go here and over there. Right?
Yes. To both doctors, you were talking about the younger relatives visiting, and I think Mrs. Trutman had a list of things that we should watch out for. But how do you address the concern of your parent that should no longer be driving?
In fact, there are a couple of cases that I basically face in our patient setting, and it's a very tough decision to take away that privilege that you cannot drive anymore. So what they have, I think, in Spalding,
Yes. Yeah.
they are doing a great job. They're doing it, and so they test you. Like you go there, and there's a testing.
I can speak to that program. We have an occupational therapist who's gone through extensive training, and with a referral from a physician, we'll do a clinic evaluation where she does some very objective testing that directly translates to one's ability to drive, and then decides whether or not it's appropriate to take that person out in the car, and she'll go out in the car with them, with a driving instructor, and actually see them doing the task and see what the risks are, and make a decision whether or not she thinks they're safe to continue driving. It's a challenging program for sure, and it's one that the outpatient social worker that I mentioned earlier is definitely involved in, because certainly on Cape Cod, our public transportation system is not as robust as many other places, so to take away that privilege of driving is significant.
Considering the discussion about DNR, it would seem that you would need to carry these forms with you if you're traveling off the Cape or cross country or some overseas even. You have some comment on that?
Is that to me? That's challenging for us because we can only honor Massachusetts forms.
So would you recommend that?
Yes.
That you carry these documents with you?
Yes, sir. Yeah, if a patient were presented with a situation where they were in the grocery store and collapsed, we would look for one of those forms when we were trying to find out the person's identification, that kind of thing. That would steer how our treatment went in that scenario. Otherwise, if that patient's wishes were to not be resuscitated and we didn't know that, we would attempt resuscitation.
I have a question for Ms. Gale with regard to the driving test. It's my understanding that that's a private pay. It's not covered by insurance. Can you address the cost? I've had several patients who could not afford to have the driving evaluation done.
I apologize, I can't tell you the cost off the top of my head, but there are separate costs. So there is a cost for the clinic evaluation, and then there is a cost if it's appropriate to go on the road. There's a separate cost for the on-the-road evaluation, and I apologize, I don't have those numbers in my head.
For family members that are concerned, there is a form on the registry website where any family member can fill the form out, or the doctor can, but it can be anyone done, where the registry will contact the patient and say, you need to take a driving test with us.
I went to a conference the other day that was given by Alzheimer's Services, and one of the speakers did say in the state of Massachusetts that if you are aware that somebody is unsafe on the road, a family member, and they cause an accident where there's injury or death, that you as a family member who did not report them may be held liable. That there was a test case in court that somebody did know that, you know, when the police came, they said, yeah, we knew this was going to happen sooner or later, and they were held liable.
And we do, with our program, send reports both to the referring physician, the patient or family member that has the rights to the report, and the RMB.
Other questions? You have a question?
Yes. Does that apply to teenagers as well?
If we have a doctor's referral.
Have we other questions? I have a question for Dr. Ahmed. This has to do with hospitalists. Hospitalists were just coming into vogue as I was winding down practice, so I would like to learn more about how they function. There are people who are in the hospital and only in the hospital. They may work 12-hour shifts, or I don't know how long, but if Jeff trucks you to the hospital at midnight on Saturday, they've never seen you before, they know nothing about you. And they're going to be with you for a few hours and then go home. How do they interface with the primary care docs? Now that we're going more and more to electronic records and so on, how do they find out about you? If you're comatose or confused or drunk or whatever, how do they get any information from your primary doctor, who is the person who knows you, but he's not there?
It's challenging. When you see, like, when you, in fact, an ER physician sees the patient first and then we admitted the patient, it's a challenge. Sometimes you don't have any history, like, especially on Cape Cod, there are a lot of people who travel from other states. We don't have any history whatsoever. So it's just basically you have to gather the data from the family members or whatever the patient is saying at that time. And then try, like especially as you said, in the middle of the night, you're not going to be able to wake up the primary care doctor and ask him, okay, tell me about this patient. So next morning, we call the primary care doctor and ask them about, if you need to gather some data from them. So yeah, it's sometimes very challenging to find those things. But again, as a hospitalist for 7 years, I feel that I spend more time with my patients. As you said, that they see you and then say bye. No. Because we have teams, like they do 5 days round, and then the next guy going to be coming in 5 days, but there's a team. So most likely you're going to be discharged in 3 or 4 days, so you're going to be seeing the one doctor, most of the time. Otherwise you're going to see this next, like the different doctor, if you are staying in the hospital for 5 or 6 or 7 days. But yes, it's a challenging thing, but now it's electronic, so you can, I'm hoping that nationwide it's going to be electronic and you can get to see other data from the other practices and other, like in Boston or in other cities. So it's coming.
That's coming. Good. Other questions? Yes. OSHA.
I would like to compliment your people for good work you're doing. I grew up in Tokyo, and I came to this country when I was 23 years old. So I have a brother and 2 sisters, all live in Tokyo, and I kept close to my high school friends and college friends for a number of years. And so I hear many things about the medical care in Japan. They have a universal care. You can walk into any hospital and see a doctor. They're highly restricted, so a doctor can give you only 2 minutes or something like that. But I have 4 close friends, and one had brain cancer, and he battled for 8 years and he died 2 years ago. And one had a prostate cancer, he died a year ago. And doctor told this patient, said there's a great, good medicine discovered in the US, but I'm sorry, I can't give it to you because government would not permit. And that's one of the sad story. Also, another friend who died, well, somewhat negligent. But anyway, doctor told them, my friends, although we have universal care, we are 20 years behind the USA. And so I want you to know that people here should consider lucky to have a good medical care.
Other questions? Well, I have a tiny story, maybe a question for Dr. Ward if you're game. My father-in-law, age 93, had Alzheimer's quite badly and was housebound and had 4 daughters. And he went into congestive failure. And we left him in his bed, everyone holding his hand, and he died at home. We didn't know who exactly to call. We called the police department, and they showed up and were very accusatory. Did we kill this guy? There's no law that says you have to take a sick parent, aging with Alzheimer's, end-stage cancer, stroke, whatever other medical problems they may have, quality of life questionable. There's no law that says you have to go to the hospital. And my question is this something we should promulgate, that there's no necessary reason if it's time for that person to go, or how do you feel about that issue? It often happened to me as a surgeon. A family would bring their old father to the hospital, and only an operation would save him. And I would say, look, I can operate on him, and there's 10% or 20% chance he'll survive, but he'll be the same old person with his stroke and his Alzheimer's. Do you want me to do it? And if very often they were shocked and would say, yeah, you know, let's just make him comfortable. So perhaps you comment.
I think that's wonderful. But you are sort of stuck, because if you call the police, they are required by law, I believe, to resuscitate him. There must be a certain point at which you don't. Is that right? But I hope you wait that length of time so that your wishes are not countermanded by attempted legal approach to this situation. I guess that's the only way I can answer it. I certainly think that's an appropriate way, having seen so many people with end-stage Alzheimer's. This is a wonderful way for a patient to go.
Well, my thanks to the panel, and wonderful job.
Citizens Forum, I want to thank our moderator, Dr. Sam, and the excellent presentation by our panelists. It was really enlightening. Thank you very much for coming.